of Infectious Diseases at the Icahn School of Medicine. Her interest in HIV and AIDS began while attending Harvard Medical School, when she was offered the opportunity to work for a year in 2001 as a research assistant in Uganda, studying AIDS-associated cryptococcal meningitis at the time when ART was not yet widely available and AIDS mortality was high. She is now co-chair with Dr. Judy Aberg of an NIAID-sponsored ACTG study looking at the immune modulating effects of 12 weeks of low dose versus high dose aspirin. She was recently awarded an NIH grant to study mechanisms by which anti-platelet drugs might provide immune modulating benefit in HIV. And I don't know the other words in this, so I'm going to skip it. So please welcome Dr. Megan O'Brien as our HIV Round speaker today.
Good afternoon. Hi. Thank you for the opportunity to talk. I'm going to talk today about a study that we just opened up that we're really excited about, a translational study, but the majority of my talk will be about the rationale behind the study. So just to get started, we know that the life expectancy of HIV-infected persons is approaching the general population with early antiretroviral therapy in North America. So if you start when your T cells are over 350, your life expectancy approaches those who are uninfected. If you start when your T cells are less than 350, like in many parts of the developing world, your life expectancy is less. We also know that HIV-infected people suffer from earlier non- or AIDS comorbidities. So if you look across the bars here, on the left side are HIV-infected people on ART, on the right are non-HIV infected, and for each age group, so here less than 40, 40 to 50, 50 to 60, more than 60, you notice in this gray color, these are no age-related diseases. So for each age group, there's more comorbidities, more non-AIDS comorbidities in HIV-infected versus non-infected. And the comorbidities that we're talking about are cardiovascular disease, certain types of cancers, bone disease, kidney, liver disease, diabetes. So at this point, non-AIDS deaths account for the majority of deaths in HIV. This is sort of a pie chart looking at what our patients are dying of who are HIV infected. And to try to understand why our patients are getting more of these non-AIDS comorbidities, some researchers have started to look at biomarkers, so trying to look in the blood to see if there's any biomarkers that could predict non-AIDS events. So this is one study that came out recently where they looked at the development of comorbidities and death, and what they found was that there's certain inflammatory biomarkers, specifically IL-6, TNF receptor, soluble CD14, D-dimer. So these are certain biomarkers that actually predict death. So if you have high amounts of these biomarkers in your blood, these were the people that went on to more likely to have comorbidities and die. And you'll notice that these biomarkers are actually indicative of overactivation of the innate immune system, monocytes, dendritic cells, macrophages, and also there's activation of the coagulation system. So I think this offers a clue into what might be going on with the increased risk of the development of comorbidities. So this is another way of looking at the data where a single measurement of IL-6 or D-dimer predicts morbidity or mortality over the next decade. These are not clinically available tests at this time. This is still sort of the research arena, but we are finding that the more sort of inflamed, the higher the inflammatory biomarkers our patients have, the more likely they are to go on and have non-AIDS events. So I'm going to focus a little bit more in this talk on cardiovascular risk, although we do know that there are increased risks of certain types of cancers, bone disease, frailty, liver and kidney disease. I'm going to talk more about cardiovascular disease risk today. So we know in general, these are a bunch of different studies that have been published, that the increased risk of cardiovascular disease in our patients is about 2 times the overall population. And we don't know why the cardiovascular disease risk is higher in HIV infection, but we have some ideas. So HIV itself, so at this point, if our patients stop their antiretrovirals, the virus will rebound, and so we know that the virus is persisting in lymph nodes and things like that. So there could be an ongoing low-level stimulation of the virus itself interacting with the immune system. We also know that there's bacterial translocation during HIV infection, where the gut is somewhat leaky, and there's leakiness into the blood of LPS and other bacterial products that could be stimulating the immune system. And there's also increased CMV infection, increased CMV antibody, and this is giving us a clue that there's ongoing CMV in the body, and that could be stimulating the immune system. So those are some ways that HIV itself might be stimulating the immune system. We know that it's been described that certain classes of antiretroviral therapy may affect inflammation and coagulation, although these studies are somewhat inconsistent, and I think that's an area that is a little bit controversial. For example, abacavir in some studies may increase coagulation, but in other studies doesn't. And we know from the SMART study that interrupting antiretroviral therapy increases risks of non-AIDS diseases, so we don't want to interrupt therapy in our patients. We also know that there's an increase in traditional cardiovascular risk factors: lower HDL, higher LDL, higher triglycerides, a lot more smoking in our patient population, diabetes, hypertension, and depending on the study you read, smoking rates are up to 50%. And we also have increased Hep C co-infection and substance use. So these are some ideas about why cardiovascular disease risk might be higher. And just thinking a little bit more about the pathogenesis of HIV-related cardiovascular disease, this is a interesting smaller study. So what people are starting to do is they're using imaging at HIV-infected patients versus uninfected patients to try to understand what's going on with vascular disease. And in this study, they used a PET CT scan to look at the arteries of patients. And so what they saw was that there's increased arterial inflammation in HIV-infected patients as compared to uninfected. And they also saw that there's an association between the increased amount of arterial inflammation with some of these markers of monocyte activation, soluble CD163. This is another study where they showed that there's increased prevalence of subclinical coronary atherosclerosis, and in this study they look by CT angiography. And they showed that in HIV-infected subjects there's an increased amount of non-calcified plaque. So I'm going to go into this in just a couple slides, but now non-calcified plaque is sort of the plaque in your blood vessels that's filled with inflammatory cells, foamy macrophages, thickened, sort of a thickened wall, but not yet progressed to calcifications. This is another study where they showed the same thing, that in HIV-infected patients as compared to uninfected, there is a significantly increased amount of non-calcified plaque. And this is another study looking at differences between men and women, and I thought this was interesting. So again, this is just one study, but it looks like there might actually be an enrichment for non-calcified plaques in HIV-infected women as compared to men. And down here we're looking at this marker. Again, this is a marker of monocyte activation, and women versus men and different age groups. And this is a marker of cardiovascular disease and probably non-calcified plaque, and it looks like women as compared to men is somewhat higher. And as we know, in all of our studies, there's sort of a paucity of our understanding of HIV disease in women because we recruit less women into our studies in general. So this is just sort of my schematic for looking at vulnerable plaques. So vulnerable plaques are these non-calcified plaques. They're more likely to rupture. They're filled with, these are monocytes and macrophages, so they're filled with these lipid-laden inflammatory monocytes, dendritic cells. And sort of this stage 4 is what we're seeing with our non-calcified plaque enrichment in our patient population. And then this is sort of going on to calcified plaque. But the main differences we're seeing in our patient population is non-calcified plaque. So recently this paper was published as we're trying to really understand what's going on. So they used the primate model of HIV infection, SIV or HIV infection, and they infected primates, and they looked after they had died from natural causes from the disease, they sacrificed the animals and looked at their blood vessels. And what they saw was an increase in proliferation of endothelial cells in the infected animals versus the non-infected animals. And they also saw an enrichment for CD8 T cells and CD68 macrophages. So what they're seeing in the blood vessels of these infected animals is increased proliferation of endothelial cells and increased inflammatory immune cells in their blood vessel walls. Another thing that might be going on to increase the risk of development of these non-calcified plaques is that it's been observed that there's increased levels of oxidized LDL in HIV infection. So here in red is HIV uninfected, in blue is HIV infected, and there's increased levels of circulating oxidized LDL in the blood. Again, increased IL-6, increased soluble CD14, increased soluble CD163. These are sort of the markers of monocyte activation we look at. And over here, they wanted to sort of just get a sense for what might be happening. So they did some in vitro studies, and they incubated monocytes with LPS, LDL, or oxidized LDL. And what you'll see here is there's an enrichment for inflammatory monocytes when they're incubated with either LPS or oxidized LDL, but not so much for LDL. This is one study that a lot of people talk about, the Saturn study, that has sort of gotten the field very excited about the potential use of statins to decrease inflammation in HIV infection. So in this study, they used rosuvastatin, and they treated HIV-infected patients for 48 weeks. This study, the majority of patients were undetectable when they started treatment, but not everybody. And the key thing that's important about this study is that they actually included patients who had very high levels of inflammation. So to get into the study, you had to have a CD8 T cell activation levels greater than 19%, and you had to have a CRP greater than 2. So these were HIV-infected patients who were not necessarily on treatment, who were enriched for inflammation. And in this group, what they saw was a reduction of monocyte activation, a reduction of inflammatory monocytes, a reduction in, this is sort of a signal of interferon signatures, and a reduction of LP-PLA-A2, which is a pro-inflammatory form. It's an enzyme actually, but it's a marker of inflammation and cardiovascular disease. So in this study, they showed that statins might be a good candidate to treat patients who have increased levels of inflammation. There's more studies ongoing now to see whether this might apply to HIV-infected patients overall, not just the most inflamed. So what about platelets? So I'm about to sort of jump now to the study that we just started and why we're looking at this. So platelets, as I showed you before, are integral to plaque formation. So they're best known as cells that are involved in hemostasis and thrombosis, but they're also an immune cell. So platelets are innate immune cells, and this is sort of data that's really sort of evolving right now. So they express toll-like receptors. They express molecules that can endocytose HIV when platelets are activated, they can produce cytokines, growth factors, chemokines. Platelets don't have a nucleus, but they have all the transcriptional machinery that's necessary to make proteins. And so we wanted to know in treated HIV infection what's happening with the platelets. If we have more cardiovascular disease, is there possibly a role for platelet activation? So I recently came from NYU just over 2 years ago. That's where I did my infectious diseases training and stayed on to do immunology research. And so while I was there, I teamed up with a cardiologist, Jeffrey Berger, and we did this small pilot study. So this is some slides from Jeffrey. I think really we actually show this to our patients to see if they're interested in joining the study, because I think it really shows clearly what we're looking at. So in blue, these little dots are HIVrelated cells. This is a cell line that's endothelial cells. So these are basically endothelial cells. And when you take platelets from a healthy donor and you put them on top of these cells, they don't really stick that much. Thrombin is a platelet activator. So when you activate the platelets, they do stick more. But what you'll notice in HIV is that even at baseline, without any exogenous platelet activator, there's in green are platelets that are stained with a green fluorophore, and you'll notice that the green platelets are sticking and much more abundant in general with the HIVrelated cells. And if you activate the platelets with thrombin, it's really sort of a big mess of platelet aggregation. So I think visually this is very striking to show that there's something going on in HIV infection with platelets. And some patients have asked me, is that me? Is that everybody? And this is really just a handful of patients. This is part of why we're doing the study. We don't actually know. We don't think that all HIV-infected patients have such high platelet aggregation. We think it's probably a subset. And, eventually maybe that subset would be the one that would benefit more from interventions. So in our pilot study, we looked at 25 HIV uninfected subjects, 25 HIV-infected subjects, all on antiretroviral therapy for over 6 months undetectable. And we did a lot of different measurements of platelet activation, immune activation, and then looked after just 1 week of low-dose aspirin to see what that would do to both platelet activation and immune activation. So here, looking at urinary thromboxane, which is a measure of platelet activation and also an overall measure of cardiovascular risk, you'll see in HIV-infected patients that it's higher. Here we did a platelet aggregation assay, so we took patients' blood, we stimulated it with different types of agonists that would stimulate platelets, and we looked to see, basically just looked at their aggregation. And we looked at many different stimulants. Arachidonic acid is one, epinephrine, ADP, collagen. This is just one example, but what we saw overall was that patient platelets, HIV-infected patient platelets, were much more likely to aggregate in response to agonists. But what we did appreciate was that it looks like there's a bimodal distribution. So even though our patients overall have more hyperactivated platelets, it does look like there's a subset that's the most likely to aggregate. So like I said, we gave a week of low-dose aspirin just to see what would happen, and I'm not showing the data here, but overall, aspirin did decrease platelet activation in our patients equally to uninfected control, so aspirin does block platelet activation. And we looked at soluble CD14 as one of these markers of monocyte activation, and what we saw was over a week of therapy, there was a decrease in monocyte activation. We actually saw this for healthy controls as well. In the patient population that we looked at, their T cell mean was 630. There was a mix of different types of patients. We did have an enrichment for smokers, 56%, and they were all undetectable on antiretrovirals for more than 6 months. We also did some other assays. We incubated their white blood cells with agonists, and we saw that after a week of aspirin, they were more functional. We also took platelets from our patients and incubated them with monocytes and showed that they were more likely to cause platelet monocyte aggregation, and this improved after a week of aspirin therapy. So it did look directly like the platelets are activating the monocytes, and like I said before, it seems like monocytes differentiating to macrophages and foamy macrophages and inflammatory monocytes really seems to be driving the disease progression in coronary vascular disease, so we thought that this was very interesting. These are just the demographics again. So this sort of brings us to, why I wanted to talk to all the groups today. So we're recruiting now for a study to really understand more what's going on with what we had observed in our pilot study. So this is a NHLBI, NIH-funded study, and it's called Targeting Platelets in Chronic HIV Infection. And the layout of the study is basically to give 24 weeks of either aspirin low dose, clopidogrel low dose, or placebo. And the reason why we're comparing aspirin to clopidogrel is because clopidogrel is a drug that's equally potent to aspirin, but it blocks platelet activation through a different mechanism of action, so it blocks ADP receptors. So we don't actually know if the effects that we saw were because of aspirin specifically or because of blocking platelet activation. So this could help us to answer that question. Most people know clopidogrel as Plavix, and it's something that we see in our patients for secondary prevention. So when patients have had a cardiac event, they're oftentimes placed on aspirin and Plavix, and those two drugs together are a very strong blood thinner. So when we think about clinical studies and giving drugs to patients, we want to think about safety. So when clopidogrel was first getting approved, they compared it directly to aspirin in a study called the Capri study. And over 1,000 patients over a year were given aspirin versus clopidogrel, and they were very similarly efficacious, and the bleeding risk was very similar. So the bleeding risk for either aspirin or clopidogrel is about 1 in 1,000. And so our study is, we just expect to have about 40 patients per year, so we don't expect any bleeding events in our study. Additionally, we just finished the aspirin ACTG study where we enrolled 120 patients. We had one GI bleed, it was in the placebo arm, and so we think that study was over 12 weeks. So we don't think that this is a very high-risk study in terms of bleeding. So the primary outcome of our study is the change in soluble CD14. For one reason was because we saw this in our pilot study, and also because we know that this is a marker that's associated with mortality. So if we see an improvement or a decrease in soluble CD14, depending on the amount of decrease, that would actually be highly associated with possible decrease in events. Secondary outcomes, this is a lot of translational stuff, but firstly it's safety, so we're not going to allow anybody in the study who has any history of a GI bleed or CNS bleed, nobody that's taking aspirin or clopidogrel, nobody that should be taking aspirin or clopidogrel for other reasons. And we're going to be looking to really understand more what changes in platelet activation might be doing to inflammation in treated HIV. We're going to be looking at IL-6 and D-dimer. Those are two inflammatory biomarkers that also predict events. We're going to be looking at monocyte subsets. These are inflammatory monocytes that aid in plaque progression. Monocyte platelet aggregates. Those are markers of cardiovascular disease and also potentially neuroinflammation in HIV. Platelet aggregometry, which I discussed before. Thromboelastography is clot formation kinetics. Atherogenicity, another marker of how the blood is clotting in an ex vivo system. And to study the monocyte function, we're looking at oxidized LDL uptake. This is, so we have IRB approved stamped flyers that are available. This is what it looks like. So part of this talk is to sort of encourage people to see if they're interested in talking to their patients about this study. So this is a flyer that you could hang in your clinics and discuss with your patients to see if they'd be interested in the study. It's a 6-month study. It's a blood donation study, and additionally, they'd be taking the study drug. And if anybody is interested, I have cards to share, and also they could call this number, which is on the flyer. That's the Clinical Translational Research Center. Judy Aberg is the director, and that's our HIV research center uptown at the Mount Sinai campus. And then this is another sort of informational document that's available, not to sort of hang in your clinic areas because it's not IRB approved, but just to sort of remind providers who's able to join the study and sort of what the commitment is. So it's anybody who's over 18, anybody who's HIV infected but undetectable for more than 48 weeks. Nobody should be requiring aspirin or clopidogrel, no history of a major bleed, not taking a statin. This is sort of key because statins are being looked at also as a potential immune modulator in HIV, so we don't want to complicate the picture. And then lastly, we'd want them to come uptown to the CTRC for all of their visits because all of the platelet and monocyte studies are done fresh and they're done within 30 minutes. So it's 7 study visits over 6 months, and we also want them to be in the morning so that they're fasting. This all affects platelet reactivity. So that's basically the talk. I'd like to thank mostly our study participants, and also this is the group up at the Mount Sinai campus who's helping with the study. These are some of the clinics that we've started to recruit participants from. This is Bellevue Virology Clinic was where we did the pilot study where I was working before. And these are some important members of the lab, Jeffrey Berger and Nicole and Emanuela, who I showed some of the data today. So thank you for your attention, and I'll take any questions.
Thank you, Megan, for the call, for the talk. I wanted to ask you a question regarding the inclusion
Hi,
criteria.
sorry, can you just wait just 2 seconds? We're having some audio visual. We'll do the roll call in just a second. Okay, great. So sorry about that. My mic was not working. Before we take questions, I just need to make a reminder about the CME forms. So we've been having a little bit of a challenge with the CME forms. So just a friendly reminder for people to please make sure they clearly write their name. So don't like scribble a signature. If you'll make sure that you clearly write your name. This is how the CME office is able to print up your transcript that you'll later download. So if they cannot read your name, they cannot put you in the system. So just, again, please print clearly on your CME forms. Before we start with the questions, I just actually had a question for you. How many people are you trying to enroll?
We're trying to enroll about 40 per year, so we have, the whole study would be 120 people, but about 40 per year.
Okay, great. So let's start with St. Luke's. If St. Luke's has any questions. Can I see St. Luke's? Okay. Okay. I can't say St. Luke's unless somebody actually says something. Maybe they're muted. I don't know. All right. Well, we'll come back to St. Luke's. I don't know who started to ask a question, which side it was. Can that person? Okay, great. I see you waving. Okay, go ahead. I think that's Jack Martin.
Yeah. I just had a question regarding the inclusion criteria. You said that they have to be undetected for 48 weeks. Did you specifically require in the study a specific regimen? What I'm trying to ask is the drug interactions with certain ART regimens and clopidogrel and aspirin. So if you're kind enough to elaborate a little bit more on that.
Sure. So any regimen is allowed, and there's no major interactions with either aspirin or clopidogrel.
Thank you.
So I'm going to go back to St. Luke's and see if they were unmuted. If anybody has any questions from St. Luke's, you could just say yes or no. Okay. We see you waving, but we don't have any, we can't hear anything. Okay, so we're going to move on to West 17th Street to see if anybody from West 17th Street has any questions.
No questions.
Okay.
Thank you.
Great. So now we're going to move to 275. I know Dr. Urbina is there. Hello? Are they muted? Okay. Hi, 275, can you hear us? Okay. No, we're looking for 275, Dr. Urbina. Okay, we don't hear him. Hello, 275. Okay, now St. Luke's is popping up.
Hi, Terry. Can you hear
Hi,
us?
now we can hear you. Thank you.
Hi, Terry. It's Chris. Well, I had a quick question, and I'm sure it was mentioned, but someone with platelet activation, what clinical implications would that have for a patient on a day-to-day, long-term, over multiple years level? What would they sort of see? Is that CBP events? Is it what clinically would that look like over a long period of time?
Yeah, so we don't know the answer to that question, but we would hypothesize that that chronic platelet activation would indeed be contributing to cardiovascular disease and basically all of these comorbidities if they're related to innate immune activation. So if your platelets are always activated, they're producing cytokines, chemokines, they're activating monocytes and other innate immune cells. Those are producing cytokines, and that's really what's contributing potentially to immune suppression in terms of cancer development and cardiovascular disease in terms of the pathogenesis of how these plaques are formed. So the hypothesis is that over time, chronic platelet activation would be contributing to potentially all of the comorbidities that we talk about, but we don't know until we really study it. And we think one of the best ways to study it is to try to look by blocking platelet activation with these different medications that are sort of well known and well tolerated and minimal risk, to see if really giving an adjuvant like this to antiretroviral therapy could potentially decrease the risk in the future of these comorbidities. This study is really sort of a biomarker surrogate study, so we want to see if there's patterns of improvement of inflammation, but obviously the bigger study, the more conclusive study would be to actually test these drugs over many thousands of patients and look for decreases in events.
Thank you.
Thank you very much.
Great. Any other questions from St. Luke's? Okay. So Dr. Urbina just sent me a text. He has no questions. Unless anybody else has any questions, we're going to wrap up. But just to say, oh, do we have a question? Okay, if you'll come up to the mic.
I'm one of the cardiologists here. I'm actually going to be starting in the HIV clinic. That's very good talk. I actually just have one of my questions was also regarding kind of hard clinical endpoints and whether that would be something that you'd be studying in the future. So I think you answered that. But my other question is, I encounter a lot of these patients with hypertriglyceridemia into the 800,000 range. I'm just wondering if you could comment on your experience with platelet aggregation in those patients or hard clinical endpoints with regards to that. Secondly, would a fibrate be contraindication to entering your study or not? Thanks.
So the first question was about the hard endpoints, and that's, I think we do these smaller studies to sort of prove feasibility and also interest, and those are very big, expensive, long studies. So I think that would be the ultimate goal, and that would really answer the question. But I think we sort of want to do these smaller biomarker studies first, and imaging studies and everything else that we're doing in the field to really understand which drugs we should go after, whether it's antiplatelet therapy or statin therapy or something else. There's actually many therapies that people have been looking at. So that was the first question. The second question, the high triglycerides. So we do see that in the clinic. I think that you may see, as sort of a cardiology specialist, you may see it more. So like across the board, when we see our patients in clinic, it's not something that is very common. But if we do see it and we provide the appropriate therapies and it still doesn't resolve, then we refer them to you. But I think overall it's not a huge problem in our clinic, but we do see it, and we do usually we're looking at other, because we know the drugs to use for triglycerides, and if their triglycerides are still high, we usually send them for more help. So lastly, we don't really know about the interactions between cholesterol and platelet activation. We do know that statin therapy does decrease platelet activation, so that's an interesting thing that people aren't really looking at in the statin trials that they've done so far, but that would be interesting. We do measure the lipids in our participants in this study. Unfortunately, if you have high cholesterol, you'll be on a statin, and that's one of the things that we're not allowing in this study. But going forward, we're interested in doing other studies in high-risk patients, for example, smokers. So HIV-infected smokers, we know that it's very hard for them to quit, even in smoking cessation trials, maybe 10% of them quit. So there's an enrichment for smokers in our population, and a good question would be, would they benefit from something like combination therapy? Are they as high risk as, we traditionally think of as like diabetics? So while we're not looking specifically at the interaction between platelet activation and cholesterol, we will see some range of cholesterol, and we will be able to see if those highest, sort of most platelet aggregatory people have higher cholesterol. We're not really powered to look at that, but that's an interesting question and something we could look at in the future, especially if we can do those studies where we're replacing patients on statin and aspirin therapy. Thank you very much.
Any other questions, if you'll come up to the mic?
How much does treatment with antiretrovirals affect this platelet dysfunction? Are any antiretrovirals better than any others?
That's a great question. So in our study, we only looked at patients that were treated, because we think of that as the gold standard. So we're really interested in looking at an adjuvant to antiretroviral therapy. But in older studies, there's even more platelet activation in untreated patients. Also from clinical experience, patients with AIDS oftentimes even have like thrombocytopenia, and the mechanisms for that are not completely worked out, but it's thought to be in part due to overactivation of platelets and consumption and high turnover and things like that. So that's definitely an incompletely answered question, but overall, antiretroviral therapy brings down platelet activation. In our very, very small study of 25 patients, we didn't see any association with therapy and platelet activation. For those sort of highest platelet activated people, we didn't actually see a great association with anything aside from monocyte activation. So we didn't really see that there was a drug effect. Even smokers, you would expect them to be the highest. There was really a mixed bag with the smokers. So, who has the highest platelet activation? It's associated with the highest monocyte activation. And what's really driving it, we don't know, actually. But from our small study, we couldn't really discern an effect, and abacavir didn't really fall out either. That's a great question.
Anybody else before we close? Okay, great. So this morning, when Naomi sent out information about today's HIV rounds, she sent to each of the coordinators at each site the flyer. We'll also follow up by sending the recruitment flyer to each medical director to hopefully bring it up at their clinical provider meetings and figure out a way to help you guys recruit for your study.
Great. Thank you
Great.
so much,
Okay.
everybody, for your attention.
Great. Thank you very much.